masih banyak kita temui di sehari-hari, baik di komunitas maupun juga di rumah sakit. Thank you for Dr. Phoebe Williams for your kindness and to share your knowledge with us. It is we are very happy and honorable to have you here. I hope you have a pleasant stay in Indonesia. I hope our colleagues, Dr. Nina and team will assist you during your stay in Indonesia. We hope that your knowledge regarding streptococcal infection will be very beneficial for us. As you know that the participants of this lecture is our residents, also our fellows, our pediatrician, also there's general practitioners from all over Indonesia, because this is an online session. So I hope that your knowledge will be applicable for their daily practice. Terima kasih pada Dr. Nina yang juga bersedia untuk menjadi moderator pada hari ini, menyediakan waktunya walaupun sedang sibuk sekali di S3-nya. Semoga hari ini bermanfaat untuk kita semua. Terima kasih pada panitia PKB yang selalu menyediakan waktu untuk mengatur bagaimana membuat pembelajaran ini berjalan dengan lancar, continuing medical education bisa dijaga dengan kualitas yang baik, apalagi hari ini ada tamu dari luar negeri yang mungkin bisa memberikan insight baru tentang streptococcal infection yang juga sangat banyak di Indonesia. Terima kasih sekali lagi, mudah-mudahan acaranya bermanfaat. Selamat mendengarkan. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, and today's event will be moderated by Dr. Nina Dwi Putri, Master of Science, Anthroped, Specialist Anak Konsultan. To Dr. Nina, the screen is yours now.
Thank you so much, Dr. Pratama, for hosting this event, and especially thank you for our head of department, Dr. Fatima Safira Latas, who currently in Singapore for the special event, but still with us with the video recording to open this session. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon. I saw in here there is a lot of professors, doctors, and colleagues, and also students and residents. And today, very today, Dr. Phoebe Williams and team, also Michelle. And I would like to introduce Dr. Phoebe Williams, our guest today. She is the ID consultant in Sydney Children's Hospital Network, and also senior lecturer in University of Sydney, as well as researchers in several important aspects of infectious disease, especially in antibiotics, streptococci. And also we know that Dr. Phoebe Williams is our collaborators, not only in Jakarta, but also I have my colleagues here, Dr. Leni and also Dr. Yadi from Bandung. And please welcome Dr. Phoebe Williams to give us a lecture about streptococcal infection. Please, Phoebe.
Thank you so much for that very, very warm welcome, and as always for hosting us here in Chipto, and for the incredibly hard work that you put into many of the research studies that we're doing with you. It's always a real pleasure to be here. So I'm just going to share my screen. As many of you might know, our research here, in Chipto is largely based around neonatal sepsis and antimicrobial resistance, and we have a consortium across Southeast Asia called the NEO-SEEP collaboration. And so the bulk of my research is usually in antimicrobial resistance and particularly how that affects babies. But today I was going to talk to you about streptococcal infections, because I understand from Nina that you're seeing a lot of children with invasive bacterial infections since the lockdowns have relaxed. And certainly in Australia, we're seeing lots and lots of invasive streptococcal infections. And I'm sure that many of you have seen that this is a pattern that first was noted in the Northern Hemisphere towards the end of last year. And so I thought I would just give a bit of an overview as to what's happening globally for streptococci, and talk through a couple of the cases that we've had in Sydney, and some of the management and diagnostic dilemmas with strep infections. So this is our sort of common inpatient list at the moment, and normally in my hospital in Sydney we would have a real variety of patients that we're seeing that would have everything from, you know, urinary tract infections to bone and joint infections to return travelers that might have dengue, but at the moment really the bulk of our consults are lots of young children that are very, very sick with sepsis and empyema. And you can see there the age in our consult list here and the visit reason. And lots of these kids are coming in incredibly unwell with septic shock. And we, in the last month alone, we've needed to put 4 of those children on ECMO. So this is quite unusual in Sydney, which is where I work predominantly as a clinician. Normally, children that do have sepsis in Australia would, you know, not need much more than a 20 ml per kilo fluid bolus or 30 or 40. And so for us to be having children that are coming in, sorry, for us to be having children that
dari RSPAD saya dapat.
Should I be?
Baru mulai.
So yeah, so for us to be having children that are coming in so critically unwell, and we're also seeing a lot of these children die, is really unusual for the epidemiology that we would normally have in Australia. So given that there's a few residents on the call, let's go right back to the beginning and talk about, you know, the basics of streptococci. So these are gram-positive catalase-negative cocci that occur in pairs or chains, as you can see here on these beautiful microscopy photos. Now, when I was doing my ID training, I was taught by Professor David Isaacs, who's one of the sort of fathers of pediatric ID in Australia. And he always helped us to remember the call about gram-positive cocci in pairs always meant that you had to be thinking about sinister streptococci, because that's like sinister twins that are there on your microscopy. And now every time I get that call, I think of those, you know, eerie twins and making sure that you do have the right management plan in place for those patients, because these kids can deteriorate very, very quickly. It's also worth noting that children that might have had pre-treatment with antibiotics, or if you have a culture that's a bit older, they can lose that gram positivity. So sometimes you'll see gram variable stains, or even have microbiologists describe it to you as gram negative cocci. So it's worth making sure that you're considering that when you have a clinical history that's consistent with a child that sounds like they might have a streptococcal infection, and then you get some confusing news from the lab with the gram negative cocci noted. And if you later realize that that child's already been on antibiotics, or that culture might have been, you know, sitting for a while before it was, the test, sorry, was sitting for a while before it was proceeded to microscopy, that can really affect the picture that you see on microscopy. So streptococci are divided into 3 broad groups based on the way that they hemolyze blood agar. So there's beta, alpha, and gamma hemolysis, which you can see in the photos there. In beta hemolysis, you've got complete lysis of the red blood cells in the agar. In alpha hemolysis, the hemolysis is incomplete. And then in gamma hemolysis, you don't get hemolysis of that blood agar. And then the Landsfield serological grouping is based on the antigenic differences that are in the cell wall carbohydrates of streptococci. So you would all be aware from medical school that there are obviously many different Landsfield groups of streptococci, and there's many, many different species of strep. And you would have come across many of these, I'm sure, in your clinical work. There's some that might just be contaminants. You know, if you see an oral strep when a blood culture is taken, some of these are really well known to cause collections of infections, particularly in the CNS, and that's often your strep anginosus group. But today I'm just going to focus on a couple because we don't have time to go through all of them today. And that's the two that are really causing the most significant burden of disease in children globally at the moment. And that's group A strep, or Streptococcus pyogenes, and Streptococcus pneumoniae. So let's start first with group A strep, or strep A. And in fact, when I was just logging on now and checking my internet connectivity, the main news story in Australia today is, scientists and doctors are warning about highly fatal strep A resurgence that's being seen in kids. And I'm sure that many of you might have seen these articles. The one on the left is from the UK, the one on the right is from Australia, because really there is a very, very high number of children currently coming in with invasive group A strep infections. And that they won't always present with sepsis or septic shock, but you could be seeing kids with empyema, sometimes bone and joint infections, and sometimes even CNS collections. So there's many different diseases caused by group A strep. As you would know, there's the superficial infections, and that includes pharyngitis, impetigo, and also scarlet fever, which I'll touch on shortly. And then there's the invasive group A strep infections. And in Australia, invasive group A strep infections are actually now a notifiable disease. They've been notifiable in the UK for a long, long time. And so the UK therefore has some really good epidemiological data around strep infections in children. But then there's obviously also the sequelae from group A strep infections and the post-strep challenges that you can see, which include rheumatic heart disease, acute rheumatic fever, and post-strep glomerulonephritis. In Australia, rheumatic heart disease is a huge, huge problem in our Aboriginal children, and we have one of the highest rates of rheumatic heart disease in the world. So this is a bacteria that's really very, very relevant in Australia as well as globally at the moment. So strep pyogenes most commonly causes pharyngitis. That's the most frequent clinical manifestation that you'll often see of this bacteria. And one thing that's really quite unique about strep pyogenes is it's a bacteria whose only reservoirs are skin and mucous membranes of the human host. And that is one of the reasons that vaccine discovery has been so challenging for strep A, because doing studies in animals is impossible, because strep A only survives within a human host. And that has really resulted in it being a bacteria that we've been much slower to find a vaccine candidate for. So strep pyogenes is the most common cause of bacterial pharyngitis in children and adolescents. Of course, the most common cause is actually non-bacterial causes, so viruses. But 1 in 5 children will be carrying strep pyogenes at the back of their throat at any time. And so it's there's a lot of controversy around the role of swabs for sore throats in children, because if they have a viral infection but might be just concurrently carrying strep pyogenes in the back of their throat, it might still be the virus that's causing their pharyngitis. And so we usually tend to try and only swab children that have really just an isolated sore throat as their sign. So let's talk through some clinical cases now, and to sort of have a think about how this might present in children and some of the cases that we've had recently at my hospital in Sydney. So the first is a 5-year-old girl who was otherwise well and fully immunised and came in with a 5-day history of vomiting, diarrhoea and fevers. So really non-specific signs. Obviously, as a paediatrician, your first differential for that group of symptoms in a otherwise well child would be a viral infection. And so she was seen in the emergency department. She passed what we call a trial of fluids, so was able to tolerate fluids in emergency, thought to really look viral with that pattern of her symptoms, and so was discharged and told to come back if she deteriorated. And unfortunately, the next morning she woke up and her mother noted that she was walking unusually with a left-sided weakness. They came back to hospital and her white cell count was 16 with a very high CRP of 395, and she was also starting to be coagulopathic. She had a CT that was non-contrast in the context of her left-sided weakness, and that revealed a subdural empyema. She was taken to the operating theatre where a craniotomy was performed, and purulent fluid was expressed under very high pressure as soon as they incised her dura. And they saw that purulence was extending all throughout her brain, through the arachnoid layer and within the sulci of the parenchyma as well. The next day, her blood culture was noted to have beta hemolytic strep on microscopy, and later that was confirmed as Streptococcus pyogenes. And so here's what her MRI looked like. This is actually the day after she'd been to theatre, and you can see there was still a really significant collection there on her right side. even after the drainage of that purulent fluid under high pressure. The next case was an 18-month-old male who also was fully immunized and otherwise well, and again came in with a 5-day history of fevers, coryza, and reduced oral intake. So again, very typical viral symptoms and commonly, something that you would put down to a viral diagnosis in children. When he was examined, his breath was noted to be malodorous, he had a red throat, and his tympanic membranes were also red. A blood culture was taken, which later revealed Staph epi, and so that was obviously presumed to be a contaminant, and he didn't need any antibiotics. But because of his sore throat and his malodorous breath and looking a little bit dry, he was actually admitted to receive some NG rehydration. The next evening, he was much better, so he was discharged, and again, his family were told to come back if he deteriorated at home, and unfortunately, the next day he did deteriorate, and he was noted to be quite lethargic at home, and again, similar to the last patient, he was noted to be walking a little bit differently and not putting much weight on his right leg. When he presented to ED, there was some edema that was evident over his right thigh, and he progressively in the emergency department quite quickly became more lethargic, tachypneic, tachycardic, and then dropped his blood pressure. A VBG showed he had a pH of 7.2 with a lactate of 5.2. His white cell count was 13. And he had a CRP of 173 and also was starting to be coagulopathic. He had an acute kidney injury with his creatinine rising to 88, and he had a very mild transaminitis with his LFTs. Now, these photos have been shared by this patient's mother with their consent, and in fact, she really was keen to share her child's story in these photos because she's keen for his story to be something that educates clinicians globally and tries to ensure that patients like this are picked up really quickly and receive the best management they can as soon as they can to try and prevent complications. So when the mother sent me these photos, she included some captions, which is what you can see that I've included there in the quotation marks. So on the left, you can see this is when the patient arrived in ED at around 11 o'clock in the morning, and his mother noticed that his right leg was getting swollen. That's that sort of mild edema that you can see occurring there on his right lower limb. 5 hours later, some discoloration started to be evident. And just like in Chipto, we have a lot of trouble with our beds. And because of bed pressures, this child still hadn't been admitted and was just sitting in emergency waiting to have, a bed and some definitive management. And his mother was the one that noticed this discoloration occurring. When she let the doctors know and they noticed that his, hemodynamics were becoming unstable, he was quickly reviewed by a medical team, and the intensive care team also came down. He was transferred to the intensive care unit, and he ended up needing to be intubated due to his rapidly declining GCS. He then required inotropic support, and he was treated with... Not sure if that's a question, or I'll keep on going unless... So he was treated with broad spectrum antibiotics, and his blood culture also returned Streptococcus pyogenes. In terms of his clinical progress, he then developed fulminant sepsis and multi-organ failure with an acute kidney injury, coagulopathy, and transaminitis. His vasopressor requirements increased. He ended up on 3 inotropes as well as getting IVIG alongside his antibiotics. A whole body MRI was done, and there was no evidence of deep infection, but quite quickly it became clear that he was developing purpura fulminans. And here you can see, this is a child that came into ED at 11 o'clock in the morning with a mildly swollen leg. And by 8:30 p.m., you can see that bright purple color that had extended over his groin, lower tummy, and leg. This is how that rapidly progressed over the next 12 hours. You can see he started to have some petechiae over other limbs as well. And in the end, all the teams were called into ICU. There was concern about this being necrotizing fasciitis, and so an in-unit exploration and biopsy was done by the surgical, plastic surgical, and dermatology teams, as well as our input there as infectious diseases. He needed extensive debridement, and a vac dressing was put in place. He needed regular trips to theatre for further debridement over the subsequent 2 to 3 weeks, and ultimately needed a skin graft to his right leg and abdomen, and he ended up on dialysis due to his renal injury. He needed lots of medical therapy for his coagulopathy to be corrected, and ended up having a 2-month admission in hospital. And during that admission, you know, again, hospital-acquired infections are a challenge everywhere, including in my hospital. And he did have an ESBL-producing E. coli bacteremia that complicated his hospital stay. And so this is his clinical progress. You can see after his first debridement and when the VAC dressing was in place, and then later after his skin graft procedure, 6 weeks following that skin graft procedure. And this is how his limb is looking now at home. And you can see that although he's, you know, had resolution of the infection, he's got really significant scarring that's going to have a real functional impact on his mobility as he looks throughout childhood.
Satu lagi deh, satu lagi dah.
So, you know, as I mentioned at the start, there has been a real global resurgence of invasive group A strep infections, really in all settings. The warning was first heralded from the UK towards the end of December last year. And as I said, that's because IGAS has been a notifiable disease in the UK for many, many years. So they have really good retrospective data, and they were the ones that first noticed. Here you can see Scarlet Fever notifications were increasing. The light green there shows the 2022 rates, and they were well above the seasonal averages. And here on the right, you can see the IGAS cases that again were well above the seasonal averages, which prompted this first warning to be sounded. Now, just quickly to touch on Scarlet Fever, which is obviously not an invasive group A strep infection, but nevertheless can be one that causes significant morbidity and tends to be associated with the more virulent strep serotypes. But this is an erythematous eruption that generally occurs in association with strep A pharyngitis, and it's a delayed type skin reactivity to pyrogenic exotoxin that's produced by group A strep. So you only see this in older kids because you need to have been exposed to strep A in the past to have this delayed type reaction to strep A pharyngitis. So if you know, in a younger child, you'd be thinking about other causes of the oral involvement and the rash that you see in a scarlet fever patient. Generally, the rash starts in the groin and under the arms. You can see Pastier's lines, which are represented here in this image. And, you know, the textbooks all talk about circumoral pallor and a strawberry tongue. But really, once you see that sandpaper rash in a child that has a sore throat, it's always quite clear what that diagnosis is. So then in Australia, we also were starting to notice at exactly the same time as the UK that we were seeing a resurgence in invasive group A strep infections too. And you can see here, even though it was the middle of summer for us in December last year, we had very, very high rates of notification. And normally strep A would be a bacteria that causes more trouble over the winter months. So it was clear that something out of the ordinary was happening. And when you look at the age groups affected here in this bottom graph, you can see that the 0 to 4 age group is by far the age group that is most affected by this resurgence that we're seeing. And when you look at the English data, it's quite interesting to look at what's happened pre and post COVID. And this probably helps explain a lot of the resurgence that we're seeing. So younger children in the UK in the pre-pandemic period used to be responsible for the vast majority of cases. They had the highest rates of population rates of infection, with 1.1 per 100,000 in the infancy age group. Then as children became toddlers and primary school age children, that incidence would drop down quite significantly. But what we're seeing after the pandemic, as you can see over here, is that age distribution has hugely shifted. So actually the most at-risk age group now are the preschool and toddler age group. And we're seeing really serious cases occurring in primary school children, as well as that persisting burden in infancy. So England later wrote up their cases that they were seeing in this resurgence, and they noted that there had been a rise in both the absolute number of cases as well as the mortality in children that were coming in with IGAS infections. They also noted that this was occurring at the same time as a concurrent rise in respiratory viruses. Whole genome sequencing was done of the IGAS cases in the UK, because there was concern that perhaps this was, you know, a unique serotype that was causing a new, more virulent disease. But actually, most of them were the M1, which I'll talk about shortly, and part of the M1 UK clone. So what does M1 mean? So the M protein actually sits on the surface of streptococci, and it is probably the most important virulence factor that drives the pathology that Strep pyogenes is capable of. It has many functions in both impacting adhesion and immune evasion. It stops activation of the complement system. It binds host immunoglobulins. And there's many, many different types of M genes which are encoded by, which encode the M protein. And their sequencing is the basis for M typing. So there's actually more than 200 variants, and M1, M3, and M12 seem to be the most common variants that are associated with invasive disease. And resistance to group A strep actually tends to be specific to the M type that you have seen before. So even if you might have had a Strep pyogenes infection previously, usually your antibody protection is only going to be protective for that M type that you had. And that's why people can get very sick with later Strep infections in life. Strep pyogenes also has a hyaluronic acid capsule, which results in an ability to evade phagocytosis, and there's other extracellular proteins, and in particular the superantigen exotoxins, such as SPEA, are responsible for the rash that you see in scarlet fever. So here's Rebecca Lansfield, who not only, delineated the Lansfield grouping of Strep pyogenes, but also was the person that discovered the M protein. And you can see on this electron micrograph photo, these tiny little M proteins sitting there on the cell surface. And it's, amazing to think that something that small can cause so much devastation in humans. So at the time that the alert around the surge of Strep pyogenes was being disseminated globally, there was also a lot of concern that perhaps this was all due to this M1 UK variant, and it's named the M1 UK variant because it was first discovered in the UK, but it has been around since 2010. And we know the M1 UK variant is associated with seasonal scarlet fever surges and can also cause more eye gas cases than just superficial infections. And that's because it exhibits enhanced expression of the superantigen SPEA that we just talked about. Now, in Australia, there was a lot of concern that our Strep A resurgence was because there were there was perhaps a new circulation of M1 UK within the country, but some colleagues in Queensland quickly conducted some sequencing of our local Strep A isolates, and they looked at almost 320 isolates that were collected from sterile sites over 15 years and actually found that M1 UK had been circulating within Australia. You can see it represented here in the red colour, really since all the way back in 2012. What has happened, though, is it has become the most prominent variant that is circulating within Australia, and it's replaced what was previously the most prominent variant, which was the M1 global serotype. And this is probably a pattern that we're seeing worldwide. So even though M1 UK has been around for a while, it's certainly a more virulent serotype of strep, and is probably part of the reason that we're seeing so much more severe strep within our paediatric populations. So after the UK published their cases and noting that they had seen this unseasonal surge in Strep A, many other countries followed suit. So this was a report from the Netherlands, which again, you can see the number of cases before COVID, completely outstripped by the number of cases that were occurring after COVID. They noted that many of the children were not just infants, but in that the sort of toddler age group. There was a high mortality with 9 of these children dying, and there was also a significant association with varicella zoster infection, which, as you know, tends to come along with Strep A, and is particularly important in the context of the lapses in vaccine coverage that we're seeing due to challenges with rolling out vaccine programs during the COVID pandemic. The cases in the Netherlands were broken down by what type of invasive infection they were causing, and you can see they weren't just more cases, but the cases that they were having were far more severe cases. So a real surge in streptococcal toxic shock syndrome, puerperal fever, as well as necrotizing fasciitis. They also sequenced their cases to, again, try and delineate if this was a new virulent serotype, but they found that most of them were serotypes we already know about, predominantly M1, 4, 12, and 22. Then in Turkey, they also published their huge surge of cases that was seen after lockdown restrictions relaxed. And then Denmark, also similar story, a huge peak in the number of invasive and also non-invasive group A strep infections that were noted there. So is there a single highly virulent M-type that is responsible for the current IGAS surge? Probably not. So even though we know that the M1 UK serotype is starting to overtake global circulation, when you look at the isolates across Europe that were sequenced last year after lockdowns were relaxed, you can see that there's a real variation of the M-types across the map of Europe. And so it's likely that what we're seeing in the burden of group A strep infections in children at the moment isn't down to some super nasty new highly virulent M-type, and really it's that probably a combination of more global circulation of the M1 UK variant alongside other factors. So what could the other factors be? Probably one of the biggest drivers is the concurrent rise in viral co-infections that we're seeing in children who, again, have just not been exposed to many of the normal pathogens that they'd see in their childhood while they have been in lockdown. So the UK looked at their IGAS cases and then also looked at the number of children that had co-infections with viruses. And you can see corresponding to the surge of IGAS, which is represented here in the black line, there was also a lot of children getting viral infections. And when they broke that down by what types of viruses, you can see human metapneumovirus and RSV were particularly responsible for a large number of those co-infections. So there's probably many reasons that we're seeing higher than usual and unseasonal group A strep cases at the moment globally. There's the altered epidemiology with a dominant M1 UK lineage, which is more toxigenic due to its expression of SPEA. There's an immunity debt in children, and that's both a virus immunity debt as well as an immunity debt to being exposed to common bacteria that they would normally become colonized with on their pharynx during the process of infancy, like strep pyogenes. And there's also enhanced clinician awareness. So, certainly, I think many more clinicians are now doing throat swabs for children they're worried about with a sore throat. Many more people are picking up Scarlet Fever. And I think that combination is responsible for the huge surge that we're seeing globally in the number of strep A cases in children. So the WHO also agrees that this is probably a multifactorial, phenomena that's driving this resurgence. And they describe in one of their media alerts that the multinational nature of the current signals suggests that the phenomenon is probably most likely related to decreased exposure to group A strep and other childhood infections during the coronavirus pandemic. And we really, while we've protected everyone very well from COVID-19 through the pandemic, we haven't given children the exposure to the normal viruses and bacteria that they would see in that early childhood period. And so they're getting far more serious viral infections, as well as far more morbidity and mortality when they do get concurrent invasive bacterial infections. Now, I just wanted to quickly touch on, what are the vaccine prospects for strep pyogenes? And I know you do a lot of great vaccine trials here, so this might be something that becomes relevant for you. But again, the M protein, although it's highly virulent, it's also the most likely potential vaccine candidate for a strep pyogenes vaccine. It's been the major focus of gas vaccine development for almost 100 years now. And initially, the focus on vaccine development looked at the whole M protein. And there were many thousands of both adults and children that were recruited for studies between 1940 and 1960, but subsequently many of those studies were shut down by the FDA because there was concern around, potential autoimmune epitopes and the safety of those trials. And that really set strep A vaccine development behind by many decades, and is probably one of the main reasons we, have been able to do so much for vaccine development for Streptococcus pneumoniae, while strep pyogenes has lagged, because after many of those trials were shut down, even though many of them showed that many of the participants didn't have any serious adverse events, it was very, very hard for people to subsequently get funding to continue to try and, proceed with vaccine development against this bacteria. As I mentioned at the start, one of the most challenging things for strep pyogenes is because, humans are the only host, it really does require human challenge studies for vaccine development to proceed. There's a group in Melbourne, in Australia, that are doing a lot of work in this space, and this is one of the papers that they have recently published. And they're always looking for PhD candidates. So if anyone is really interested in Strep A and thinking about spending some time in Australia, I'd really, suggest they're a really fantastic research group to work with. The vaccine research into Strep A in Australia is one of our core, research strengths in Australia. And that's largely because, as I mentioned before, we do have a really terrible burden of rheumatic heart disease in our Aboriginal paediatric population in Australia. And so we really focus on Strep A vaccine development as an activity that might be able to help reduce this burden over the course of our clinical careers. So Group A strep vaccine development has been really challenging over the last 100 years, and that's because there's extensive genetic diversity with all those many different M types that we talked about before. There's potential autoimmune epitopes, and engaging regulators and trial funders to be able to support human challenge models has been something that has needed a lot of work. Currently, there's only 4 vaccine candidates that have progressed to early stage human trials, and all of those target the M protein, but there are some non-M protein vaccine candidates that are also under development. And this is a summary of some of the M protein vaccine candidates that we might start to hear more about over the next decade, that have gone through some phase 1 studies in a small number of participants and shown good efficacy, with showing that they're immunogenic and quite safe. So let's quickly touch on the management of IGAS infections. So I'm pleased to report that things have improved since this historical review, which talked about how Strep pyogenes was managed in the time of the war. Back then, it really was debridement, which is obviously still a very important tool where we need source control, antiseptics, irrigation, and all sorts of strange things that were administered topically. But what we were realizing from right back then was that these patients did need isolation, because these pathogenic serotypes do tend to be quite transmissible, and you can get clusters of severe Strep A outbreaks. And we were also starting to realize that the impact this bacteria has on infections can be really similar to a burns patient. And in Australia, frequently burns units might be responsible for looking after these patients after they have had the initial infection controlled. So prompt recognition and management has a huge impact on morbidity and mortality outcomes for children and adults that have invasive Group A strep infections. And that will generally require source control, and that could be anything from the purpuriforminins that we saw earlier in this talk to an empyema that needs drainage, which might be a respiratory empyema or a CNS empyema, again, that was we saw in that first case. And you also need prompt administration of benzyl penicillin, which is the antibiotic of choice for strep pyogenes, plus or minus IV clindamycin, which we would normally give for children that are hemodynamically unstable, and IVIG, which again is something that's usually reserved only for people that are exhibiting symptoms suggestive of streptococcal toxic shock syndrome. So IVIG can be a little bit controversial. Some clinicians feel that's very expensive and doesn't necessarily have a huge impact. Other clinicians will give it even before there is evidence of that, hemodynamic instability. But there are a number of studies that really do show that it has quite a significant role in tempering the immune response to strep pyogenes, particularly where that toxic shock is evident. And it does that by facilitating bacterial opsonization and neutralizing many of those superantigens and toxins that strep pyogenes is so good at being able to produce. I think this is probably the strongest evidence to suggest that IVIG is helpful. This was a systematic review where they pulled together studies of children who had already received clindamycin, because as you know, clindamycin has an antitoxin effect. And so to take away that bias of what, clindamycin might have been responsible for improving, they only included subgroups that had already received clindamycin. And in all of the studies, IVIG was found to reduce mortality in children with strep toxic shock syndrome, but often it didn't reach a statistical significance level in the individual studies. But when they pooled that analysis, you can see that IVIG was associated with a reduction in mortality, and that pooled analysis was statistically significant. So the authors conclude, which I agree with, that overall, given the high morbidity and mortality associated with strep toxic shock syndrome, we support the use of IVIG as an adjunctive treatment for strep toxic shock syndrome. And that's noting that IVIG is not always available and can be very difficult to get, and is also very expensive. And even in Australia, it's quite a process for us to be able to get approval to give IVIG to children who need it. So clindamycin is probably an easier agent to access for that antitoxin effect. And we know that adjunctive clindamycin is recommended for necrotizing infections alongside strep toxic shock syndrome. It inhibits production of many of the key virulence factors that we see in strep pyogenes. And it also, similarly to IVIG, increases opsonization and phagocytosis of the bacteria itself. Interestingly, we also know clindamycin is more effective than penicillin when there's high inoculum infections, but its efficacy is gradually reducing in the context of rising clindamycin resistance. And if you do have a culture that is a strep pyogenes that's Clinda resistant, but you have a child that has a necrotizing infection or symptoms of toxic shock, it is still worth having clindamycin on board, because its toxin inhibiting strategies will still work even in the context of the bacteria being resistant in those cases. And again, this is a nice pooled analysis of many of the single studies that have been done looking at benefits of clindamycin. And you can see that overall, there is always a mortality benefit where clindamycin is used as an adjunct, but only when there's features of toxic shock syndrome or necrotizing skin infections. Now, linezolid is something that I think we will start to hear more and more about for strep pyogenes over the next decade. And just this year, just a month or so ago, this study was published in CID that looked at Clinda and Vanc versus linezolid for treating necrotizing soft tissue infections in people with strep pyogenes. It was a single center retrospective study, so limited evidence, but showed that there was similar 30-day mortality in those two groups. And even though the mortality was similar, there were many benefits to the group of people that were administered linezolid. So they had less acute kidney injuries, they had an earlier discharge from hospital, and even though linezolid is an expensive antibiotic because it's oral, it could be administered in the community. So actually it ended up cost neutral, especially when you took away the need for the therapeutic drug monitoring that vancomycin tends to require. There's been some concern about the use of linezolid with other serotonin agents, but this study actually found that even in people that were on, things like SSRIs, there was no evidence of serotonin toxicity. So that concern is gradually being debunked. And that study prompted a nice summary that was also published in CID that really shows that linezolid has quite significant promise, but we need more research. So it's got a higher susceptibility than clindamycin globally for strep pyogenes, and tends to have overall more favorable outcomes because it's got less side effects than clindamycin does, including less rates of C. diff diarrhea. And it also, one of the other benefits is that it has activity against MRSA. And as you know, sometimes distinguishing toxic shock due to Staph aureus versus strep pyogenes can be very, very difficult. And linezolid has that advantage of being able to provide coverage to both. But really, we'll need more trials before it becomes a mainstay therapy in the treatment of strep pyogenes. Now, I just wanted to touch on one last thing with regards to strep pyogenes, and that's because, why is it that even though we have this bacteria that is incredibly sensitive to penicillin, particularly when we look in the lab on a plate, we nevertheless see kids with really bad outcomes, even when they are given penicillin quite early in their treatment. That child I talked through before with purpura fulminans, he did get antibiotics on board in emergency only within a couple of hours, but nevertheless progressed very quickly to have a very devastating infection. And this is probably down to a phenomena called the eagle effect. And that means that what we actually know from studies that were conducted almost 100 years ago, around the time of Rebecca Lansfield, is that where there's high inoculum strep pyogenes infections, we probably have less activity of benzyl penicillin in vivo. The eagle effect is something that has been reported for many staph and strep and even some gram-negative and fungal species. And it's where even though you have an antibiotic on board that whereby the concentration of the antibiotic is above the MIC that we would see in the lab, you can see paradoxical growth of that pathogen at higher antibiotic concentrations. And this eagle effect might be what is driving the ongoing morbidity and mortality that we see in many group A strep infections, even when benzyl penicillin is on board. So Henry Eagle was the first person to describe this back in 1949, and he used some animal models where they were injected with very high inoculum of strep pyogenes into their muscle, and he noted that the larger the inoculum, the organism was able to proliferate and the efficacy of penicillin was reduced. Subsequent studies confirmed this and found, so here you can see in terms of the time that these animal models were treated with penicillin and their survival, the group that received penicillin alone had a really quite low survival, and that survival was impacted by a delayed commencement of antibiotic. And so that's why one of the key things for strep A infections is thinking of it early and getting antibiotics on board early. But that effect was not noted so much for clindamycin. And this is probably why we find clindamycin such a helpful adjunct in treating strep A infections. That said, you'd never want to give clindamycin as monotherapy because, as I mentioned before, there is certainly clindamycin resistance in strep pyogenes, and you also don't want to overuse clindamycin, and you want to try and save it for those cases where you have hemodynamic instability or a necrotizing skin and soft tissue infection. Now, lastly, chemo prophylaxis after an IGAS case. Again, this is something that's quite controversial. In Australia, we tend to give all households of pediatric cases who have, when there's a case of strep pyogenes, we give everyone in the household antibiotics to try and clear the potential strep pyogenes that they might be also carrying at the back of their nasopharynx. But the number needed to treat to prevent one further case of IGAS is very high at about 220. And so in the context of rising antimicrobial resistance, many people say that's a far too high number needed to treat. And really, we should not be giving antibiotic prophylaxis. So many of our adult colleagues don't, but certainly in pediatrics, we often do because as we've seen in the cases I've discussed today, the symptoms of strep A can be really subtle in children and mimic viral infections. And while it can be easier to see a subsequent strep A adult case in a household, that can be harder to pick up in other children in the household. And because of the devastating morbidity and mortality, we do err on the side of treating. If you are going to give chemo prophylaxis to household members, you ideally do it as soon as you can, but the best benefit is seen in that first 7 days after they've been exposed to a case of IGAS. And the highest risk of that co-transmission and co-infection often occurs in mother-infant dyads, as well as young children and older adults. So in Australia, we have a therapeutic guidelines that suggests for chemo prophylaxis, you can either give a single dose of benzathine penicillin or a 10-day course of Keflex, or for those that have allergies to beta-lactams, you can consider using azithromycin. All right, so I think I've got time to quickly touch on strep pneumo, but I will run through this very quickly because this part's much shorter. Again, just going back to a case and taking us now from Streptococcus pyogenes to thinking about Streptococcus pneumoniae. We had a 12-month-old male admitted recently who was otherwise well, and he was due to have his 12-month immunizations. He'd just had his first birthday. He'd commenced daycare earlier this year, and he'd had lots of viruses since, which often tends to happen. And so again, this was all quite normal. And his family had even pulled him out of daycare for a week because they were planning a big family holiday and they didn't want him to have a runny nose and a cough, and were hoping they'd all be able to enjoy their first family holiday together. But he presented with a 24-hour history of fever, vomiting and lethargy, but didn't have any coryzal symptoms. So again, very similar symptoms to the other patients we've talked about today, and really often commonly viral symptoms in children. His white cell count was 8 and he had a CRP of 239. And because of his lethargy, a CT brain was done, but that was actually normal. He later started to have some tonic seizures, and he was commenced on acyclovir, gentamicin, ceftriaxone and vancomycin at a peripheral hospital in Australia in the country. And he was then loaded with Keppra to try and reduce his seizures. He was retrieved by air and brought to our hospital, and this was his imaging that you can see there, where he had extensive leptomeningeal enhancement that extended all the way into his basal ganglia and his cerebellum. And even though his blood culture had no growth, molecular testing later revealed that he had Streptococcus pneumoniae that was detected via PCR on his blood. So that patient unfortunately died, even though he was an otherwise well child and had had 2 doses of the Prevnar vaccine and was waiting for his 3rd dose that he would receive at 12 months. And similar to Indonesia, we do a 2+1 schedule in Australia. But even with that schedule change, we're seeing lots and lots of pneumococcus at the moment. So globally, really, invasive pneumococcal disease actually all but disappeared during the pandemic. This is a graph from Japan, and you can see the green cases here are the number of IPD cases that they have every week, and those cases drop down significantly, particularly around periods of lockdowns. When lockdowns eased, there was a little peak in IPD cases, but in general, there was not much IPD seen. And in Australia, we saw not just less IPD, but also a lot less invasive meningococcal disease. So this was a study that was published by some colleagues I work with in Sydney, and their IMD cases that are tracked here in the light pink shows how low IMD cases were over 2020 and 2021. And corresponding with that, you can see that there was almost no influenza circulating. So that's the light blue line here, and that just completely flatlined over the 2 years of the pandemic in Australia. But when the lockdown restrictions eased, we saw a huge resurgence in invasive meningococcal disease, as well as Strep A infections and IPD cases. And the public health team put out an alert about that. And we've recently looked at some of our local cases in New South Wales, which is one of the most popular states in Australia. And we looked across 3 hospitals to try and understand if the cases that we're seeing in IPD in children at the moment are more severe than we would see in a pre-pandemic time. And when we looked at 23 cases, you can see that similar to Strep A, we started to see that there are more IPD cases in older children than we would normally expect. And unfortunately, almost half of the cases of IPD that we had were caused by serotypes that are not covered by the 13-valent pneumococcal vaccine. So serotype replacement is a huge challenge with pneumococcus, and as usual, the bugs tend to be smarter than us. Most of our cases also had either an antecedent or a concurrent viral infection, and certainly we're seeing a huge RSV and now influenza burden in Australia. And there was a high mortality rate, so 17% of our cases died, which is much higher than our usual standard of about 4%, and almost all the children were otherwise healthy and well children. So there's some new pneumococcal vaccines that are gradually coming to market. In Australia, there's 2 new vaccines that have been approved by our TGA, our sort of version of the FDA for adults, and that looks at a 15-valent serotype vaccine with a couple of extra serotypes covered there, the 22F and 33F. And also a 20-valent, but these haven't yet been approved for use in children in Australia. And we also have a polysaccharide vaccine, a 23-valent polysaccharide vaccine, which, while it gives extra serotype coverage, it unfortunately tends to be less immunogenic in children. And I spend a lot of my time working in the vaccine space in Australia, and I think it's important. I constantly remind my colleagues that while we and ah about which type of vaccine we should be recommending for children and adults in Australia and how many serotypes we can afford to cover with our vaccine program, there's many countries around the world where children currently aren't even eligible to receive a single pneumococcal conjugate vaccine. I know many of you here at CHIPTO have worked very hard to get this on the schedule here for children in Indonesia, and that's a fantastic thing given the burden of disease that this bacteria can cause in unvaccinated children. And it really seems that what we're seeing in terms of the current IPD surge is similar to what we're seeing in the IGAS surge. And a lot of this is being driven by a resurgence of viruses in children that haven't seen viruses over the course of the pandemic. Interestingly, there were some pneumococcal carriage studies that were done during the pandemic, and they showed that even though we were seeing a lot less IPD, there was the same amount of pneumococcal carriage in the community. And so it shows that you need more than just carriage of pneumococcal to develop invasive pneumococcal disease. And that key to, unlock carriage in the nasopharynx through to invasive disease seems to be a co-occurrent virus. So we know that viruses locally deplete immune cells throughout the respiratory system, and influenza A in particular, its neuraminidase on the surface of influenza A has a particular ability to enhance pneumococcal adhesion on respiratory cells. And really, this is something that we've known for many, many decades. And back in the Spanish flu pandemic, actually far less people died of the flu than died of Streptococcus pneumoniae. So this relationship of viruses and particularly streptococcal infection seems to be very, very strong. And so, we need to be looking not just at developing vaccines against pathogens like Strep A and pneumococcal vaccines with more and more serotypes, but also making sure that we can improve our vaccine coverage of viruses like influenza in children, given that really these will so commonly co-occur. And I think we're making some great progress in the RSV vaccine space, and hopefully when some common nasty viruses in children like influenza and RSV are better curtailed, we will start to see control of some of these invasive bacterial diseases. At the moment in Australia, we're seeing a massive resurgence of influenza. You can see here, this is a report our public health system puts out each week where they summarise COVID, flu and RSV cases. And when you look at the paediatric age group that I've highlighted here in red, you can see that they they hardly have any impact from COVID. We've known that children have really gotten through COVID largely unscathed in a virus in itself, aside from the PIMS-TS complication. But influenza and RSV is causing a massive burden in children, particularly in Australia at the moment, and really overwhelming our hospitals. And we've seen 4 children die in Australia this flu season alone, actually just from the flu, and many dozens more that have had co-infection with influenza and a bacteria that has almost always been Strep Pneumo or Strep pyogenes. Despite this, we have very poor vaccination coverage for influenza for children in Australia. It's free for children that are less than 5, and even though it is free, only 1 in 4 families will manage to get their flu vaccine for their children each year. So to bring it all together, it looks like there's many things that are responsible for the current surge in Strep pyogenes and Strep pneumoniae that we're seeing globally in children. Really, probably the most prominent cause is the disrupted circulation of endemic viruses in children that occurred secondary to the COVID-19 lockdowns that have resulted in an immunity gap, and now healthcare systems are really overwhelmed in children getting very sick with those viruses that are also occurring at non-seasonal times. Subsequent to that, we're seeing many children that are susceptible to both viruses and bacteria, and don't have that gained immunity that they would develop over repeat exposure to viruses and bacteria through their normal infancy and toddlerhood. And there's also decreased maternal exposure and passing of that immunity through the placenta in the context of many mothers also not seeing many of these pathogens over the COVID-19 lockdowns. So we're likely to continue to see out of season surges and really altered age distributions of many of these common viruses and bacteria for many years to come. And I think that, as I said, while we've done a fantastic job in curtailing COVID-19, we as pediatricians need to remember that the pandemic was about a lot more than just the virus for them, and they've lost not just many years of education, and now in many countries there's a huge, gap in education as well as a mental health burden from the pandemic. But now we're also seeing this huge medical challenge of them becoming very, very sick with common viruses and bacteria. And so in the next pandemic, I hope we can find a way that we think not just about the high-risk adults that might get viruses, but also the impact that some of our public health measures might have on vulnerable children. So that's all I have from my slides. I'm not sure if there are any questions.
Thank you, Phoebe, for a really interesting talk. And then it's open our insight regarding the streptococcal infection and also the infection after COVID-19 pandemic. Yeah, it's a challenge. Currently, we see more kids with infection. In Indonesia, we have a resurging of vaccine preventable disease, and probably group A streptococcal or other like pneumococcal infection, as I mentioned before, that not all of our hospital can grow it in the culture, so it is difficult to detect in Indonesia. So I think it's our homework to improve our lab facility in here. So in here I see that a lot of infectious disease working group. My senior Professor Hinki, Dr. Jatnika, Dr. Karyanti, Dr. Anggi, Dr. Iren is also here. Everyone who I cannot mention. I think a lot of people attend this talk. And I have 3 questions in the chat. The first from Dr. Denny. The first question is, what is the port of the entry of strep in NPMA subdural patient, and what is the antibiotic chosen in this case? So before you answer the question, I would like to do a short survey. Okay, doctor, in the past 1 month, have you seen a lot of kids with a Scarlet Fever? For example, for me, this week I see, I think 2 cases of Scarlet Fever in my practice. So you can answer in the chat, yes or not. Okay, no one? Okay, Dr. Az said yes, no, okay. How about the other people? Do you see streptococcal infection over the past months? Strep throat, yes. Okay. Okay, thank you for your answer. And then PB, I think you can answer the first question from Dr. Denny.
Yeah, thank you. So yeah, I think, like as you say, it can be really difficult to culture some of these pathogens. And you even saw with that child who had overwhelming pneumococcal disease that his blood culture was negative, and it was only the molecular test that picked up the Strep Pneumo. But I think if you're seeing scarlet fever and strep throat, then you know that you'll probably, a lot of the kids that are coming in with severe sepsis are likely to have that due to either strep A or strep pneumo. So in terms of the child that had the subdural empyema, they probably had a mastoiditis that was the source of that infection, because it was really quite contiguous in terms of, you can certainly get a strep pyogenes meningitis, but that would usually be from bloodstream spread. But this child probably had an antecedent viral infection that hadn't been diagnosed or picked up, and a subsequent middle ear infection that extended to mastoiditis and caused the subdural empyema. We treated that patient, so they were hemodynamically unstable at their presentation and did need a couple of inotropes. So because we didn't have the blood culture results, that child initially got ceftriaxone, and then because of the hemodynamic instability, we added clindamycin, and also that child did have a dose of IVIG, but then when we got the strep pyogenes back on the blood culture, we changed to benzyl penicillin and kept the clindamycin going for a few days until that inflammation had settled down and some of that toxin production had turned off.
Okay, thank you, Phoebe. Yeah, so for your information, we don't have clindamycin IV in here, and then we also didn't have benpen IV penicillin in here. So yeah, I think I want to continue with Dr. Afian question before I answer Dr. Dodi question. And then what is the indication of IVIG for I think toxic shock syndrome, and also is it necessary to check the IgG level? So I think I want to extend the questions. If we only have the clindamycin oral, can we use it, or we need to put the IV clindamycin if the baby still tolerate oral?
Yeah, that's a good question. So yes, you can certainly still give oral clindamycin. I think in the sorts of patients that you'd be administering it to, though they'd be quite clinically unstable. So you would worry about their gastrointestinal absorption and ability to, really get the benefits of that antitoxin effect for clindamycin for those patients, given that, really it's only indicated, like with IVIG, if there's toxic shock syndrome or a necrotizing skin and soft tissue infection. But certainly I think that if you don't have IV available, then oral, which might need to be via an NG tube, is certainly better than no clindamycin. In terms of the indication for IVIG, really, again, it's the same as clindamycin. It's any child that is needing inotropes or whose blood pressure is still unstable despite, a 30 or 40 ml per kilo fluid bolus, and anyone with a necrotizing skin and soft tissue infection. That said, the evidence is there with those pooled studies, but it's not particularly strong evidence. So if it's very difficult to get, don't fret that you're not able to administer it. I work with some intensive care physicians that really don't feel there's any benefit in IVIG, so often won't even give it in those indications. If you do have access to it, I definitely, given how sick these kids are, if it was my child, I would want them getting IVIG. So I tend to order it and administer it for those hemodynamically unstable children or those with a skin and soft tissue infection. And you don't need to do any monitoring. You don't need to check the IgG levels. The one thing that IVIG can complicate is the timing that they can subsequently receive live vaccines. And also, if you do any serology after someone's had IVIG, that will usually be difficult to interpret because you're testing the serum, not just of your patients, but also of all those donors that have contributed to the IVIG. So there isn't any routine testing that you need to do as monitoring when you're administering IVIG, but it can be helpful to sometimes we save some serum before we administer IVIG, so that if there are any tests that we subsequently want to do, we can do that on a pre-IVIG sample.
Thank you, Phoebe, for the really clear answer. Okay, the next question is from Dr. Dodi. How it's prevalence in Australia, and does Group A strep vaccine development included in National Health Genomic Policy and Health Alliance?
Yeah, so in fact, there was a paper that just came out overnight from some colleagues in Melbourne that has shown the prevalence of IGAS in Australia in children is rising. So we're actually, at the moment, we're seeing 4 times our baseline rate that we saw in the pre-pandemic times for invasive Group A strep infections. Vaccine development and the National Health Genomics Policy, I don't know if they, most of the vaccine development in Australia is led through the human challenge models that are coordinated largely through Melbourne, with some input from the team in Perth, who are really leaders in the rheumatic heart disease space. But certainly sequencing of our IGAS isolates does occur, as I sort of pointed out with that paper that looked at whether the M1 UK variant was responsible for our current resurgence. But I'm not sure if, I think that given they already have some products that have gone through phase 1 trials, I'm not sure if that sequencing is informing vaccine development within Australia at the moment.
Thank you. And the next question from Dr. Agung is my senior. What is the first-line antibiotic that you use if you suspect strep infection at outpatient clinic? Does amoxicillin clavulanic acid still works? And when do you consider giving clindamycin?
Yeah, that's a great question. So historically, we used to have a stratified decision-making tool for pediatric patients that presented with a suspected strep pharyngitis. We actually 10 years ago stopped giving antibiotics for children that were considered to be at low risk complications from strep A infections, and we only gave oral antibiotics to children that were particularly of an Aboriginal background or potentially immunocompromised. And that was a sort of stewardship program that was instituted in Australia. That has very much reversed in the last year in the context of the severity of strep pyogenes that we're seeing in Australia and also in the UK. So the UK also used to have a nuanced guideline as to who should receive oral antibiotics if they had strep pharyngitis. But now the recommendation is, given the virulence of the currently circulating strep pyogenes, the recommendation is that any child with presumed strep pharyngitis should get oral antibiotics. So you wouldn't give it if they have coryzal symptoms and other things that would fit with it potentially being a viral cause of their pharyngitis. But if they just have a sore throat and are scoring highly on the Centaur criteria, you would normally give amoxicillin as monotherapy. Amoxicillin and clavulanic acid actually has a lower component of amoxicillin in it than routine amoxicillin does. So you are better off to be giving straight amoxicillin rather than augmentin or co-amoxiclav. And I wouldn't suggest giving clindamycin, first of all, because it's got more side effects in terms of its risk of C. diff, but also because there are, increasing rates of clindamycin resistance in strep pyogenes globally. So if you gave that as monotherapy, there is a chance that it wouldn't work. So yeah, we would normally give any child that looks like they have strep pharyngitis amoxicillin in an outpatient setting. That said, the preferred agent is actually phenoxymethylpenicillin, but that is very poorly tolerated in kids because it tastes horrible. So we do give the slightly broader spectrum amoxicillin because it's more tolerable for kids and so therefore more likely to be taken.
Thanks, Bibi. Probably we can also highlight what is the dose of amoxicillin and also the duration of the treatment of strep group A.
Yes, I would have to check. I usually just suggest amoxicillin. So for higher doses that we're often seeing in an ID point of view, we usually give sort of 30 milligrams per kilo TDS. But I think for just strep pharyngitis, because that's normally looked after by primary care, I would need to check the dose myself in our...
Probably the duration will be like 10 days, is it?
Yeah, it is recommended for 10 days. And you sometimes see people get a relapse of strep pharyngitis even at the end of the 10-day course. And you can also see that with Scarlet Fever as well, actually. So they'll have their 10 days of antibiotics and within 48 hours, they then get recurrence of pharyngitis or even the scarlatiform rash. And with those kids, you're recommended to give them a second course. And sometimes there's suggestion of changing the agent, but usually a second course is all that they need for actual clearance of the strep pyogenes.
Okay, thank you so much. One more question is in the context of the limited research setting, since we cannot culture the bacteria and it's difficult to grow up in the conventional media, do you think that check the titer of ASO is useful to determine the diagnosis?
Yeah. So ASOT and anti-DNase B can be really helpful, but usually won't rise until sort of 2 weeks after the infection. So in the acute diagnostic phase, it's often normal. And so unfortunately not particularly helpful. So it can be really helpful when you have kids, that are coming in with potentially post-strep phenomena like a post-strep GN, or you're worried about acute rheumatic fever. But for acute skin and soft tissue infections or strep toxic shock, often that serology will lag the acute presentation by 2 weeks. So I sometimes, it can be helpful to still do the serology, order the serology, but treat as if they have strep pyogenes. And then, when you follow up those kids in clinic, you might have those results down the track and be able to do convalescent serology that can confirm your diagnosis for you, but it unfortunately wouldn't be very helpful in the acute management.
Thank you so much for a very clear answer. And then I want to invite my senior. Is there any question? Ada pertanyaan tidak dari dokter-dokter, profesor, senior sekalian yang sudah hadir di sini? Mungkin ada yang ingin bertanya langsung, boleh bertanya langsung. Silakan Prof. Inky, Dr. Jatika, mungkin ada Dr. Karyanti, Dr. Anggi. Dr. Karyanti ada di sini. Dr. Karyanti masih mute, Dr. Karyanti. Prof. Inky, ada pertanyaan, Prof? Masih mood ya kayaknya. Nggak bisa ya? Bisa. Udah bisa di mute dok. Silakan dok. Prof. Dokter. Nah, coba di mute. Itu nggak bisa di unmute. Udah bisa
Okay.
dok.
May I ask a question? Thank you for the nice presentation. We do have quite a few several children with strep group A, tonsillitis membranosa, and for the drug of choice, we do give Camoxil, but it must be 10 days. So the alternative is that our second line is the azithromycin, which we can give in 5 days, but it turned out good. The differential diagnosis that sometimes we often get is the diphtheria, tonsillitis to differentiate diphtheria, or tonsillitis membranosa because of strep group A. But in our experience, if we give the antibiotic, we usually give the penicillin propane intramuscular, but if the membrane disappeared quickly, it's more likely the strep group A, because we only have astoya for the examination for that, or do the swab and do the gram positive, which is coccus. If it's coccus, then it's more likely the strep group A. But if it's Albert or because the culture is quite long, we don't wait for the culture, we treat the patient. But that's our experience here. We're having this outbreak of diphtheria and with the differential diagnosis with the tonsillitis membranosa because of the strep group A. But it's quite often that we found now and I often have the cases with endocarditis. Sometimes after in the NICU, Nina, with the NICU, we have the infants with the endocarditis also. But maybe it can be other cause besides the strep group A with the other gram-negative bacteria. That's just sharing experience. Thank you for your nice presentation. Very fruitful.
No, it's so great to hear about the local experience, and it sounds like it's been really challenging with these diphtheria cases for you locally. Extra challenges. Always new challenges for you, you poor things.
Thank you, Dr. Karyanti. Okay. The other comment from Prof. Inky, do you want to ask questions or give comments?
Okay. Thank you for your comprehensive and complete presentation regarding streptococcal infection. Maybe I missed your speech here, but I just want to know, because the culture is also not available immediately. So you have any rapid test, bedside test to diagnosis streptococcal infection? And achievable, I mean, low cost, yes?
Yeah, no, there are some molecular rapid tests. We don't have them in Australia. So we usually, the microscopy is the first thing that we receive, but that is often, 8 hours after the patient has presented very sick. So we would often, if a patient comes in, in extremis, needing inotropic support, or with any evidence of a necrotizing skin infection, we would normally, straight away start on Benpen, Clinda, and try and get some IVIG. And it is usually subsequent to that we would get the call about the gram-positive cocci from the lab, and often then another 12 hours after that we might get the culture. So yeah, there are some rapid tests available, but we don't have access to them in Australia either.
Thank you. So you also still make a diagnosis based on a clinical appearance first, yeah?
Yeah, absolutely. Yeah.
Okay. Thank you. Terima kasih, Dr.
Thank you, Prof. Inky. Is there any more questions from the audience? You can ask the questions directly. If you want to ask the question, please raise your hand and open your camera. Who's in here? Dr. Anggi? Dr. Janika? Dr. Cece mungkin ada di sini juga. Oke. I think there is no more questions, and it's already close to 3 o'clock. And I think thank you so much, Phoebe, for Dr. Janika is here. Dr. Janika, do you want to give comment, Dr. Janika?
Yeah, thank you, Dr. Nina, and also for the nice presentation. Yeah, in our hospital also maybe some for culture, yeah, like Dr. Nina said before that sometimes the culture is not good result, and also we just only for clinical manifestation. But I think enough, Dr. Nina, for your all talk. Then thank you for your precision.
Yeah, I was just going to mention that our blood cultures tend to be also quite insensitive. If we do get a strep pyogenes, it's quite lucky. We'll often find that we'll have the clinical presentation of someone we are thinking has strep pyogenes, but often the positive culture will come from pleural fluid of a drained empyema, or we'll do a throat swab when they do present so unwell. And sometimes, you know, even though the throat swabs can be difficult to interpret because 1 in 5 kids will have strep pyogenes carriage, you know, if you've got a child that's very unwell and then you have the positive throat culture, even in the context of a negative blood culture, that can help sort of put some of the puzzle pieces together. So we usually do try and culture other sites other than just blood, because as you say, it is very insensitive and often won't give you the answer.
And what the criteria for the true pathogen, or is there's contamination for blood culture?
For which, sorry?
Or the criteria for true pathogen, or just only contamination from the blood culture result?
For the child that had the staph epi,
yeah,
sorry?
If the result is positive, is true pathogen or just only contamination? Do you
yes.
have criteria?
So we would, in any immunocompetent child that doesn't have a long line in place, we would always consider a coagulase negative staphylococcus to be a contaminant. So that's why that child I mentioned in my presentation, you know, wasn't recalled for any antibiotics. And then we also have some sort of, you know, oral pathogens like strepmitis or strep oralis that we would usually also consider contaminants when we get those results from the lab.
Yeah, thank you.
Thanks.
Thank you so much, Dr. Jatika. And yeah, because it's already 3 o'clock, yeah, apologize. We need to close the session today. And thank you so much for PB who already gave talk regarding streptococcal infection. And it is really useful to open our eyes about the resurging several infections. This is not only the diphtheria, pertussis, and also measles and rubella, but also streptococci infection. And thank you for all the participants. I see it still 300 plus people in here until the end of the talk. And also thank you so much for the Department of Pediatrics and also the team of continuing medical education. And also thank you for all the ID working group who already attend this meeting. Over back to Tama.
Yeah, thank you, Dr. Nina. So we have reached the end of the lecture for today. Once again, we would like to thank Dr. Phoebe Williams for delivering this important lecture to us today, and also participants who have attended this lecture. So good afternoon and have a good day. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much.
Thank you. Thank you, Dr. Phoebe.
Thank you, Bibi. Prof. Inky, Dr. Jatika,
Ya,
Dr. Priyanti, Dr. Cuce.
Nina,
ya,
Dr.
terima kasih
kasih.
Dr. Nina, Dr.
Terima kasih semuanya, senior semua
kasih Dr. Jatika.
Ya,
Dok.
sama-sama.
Terima kasih Dokter Kama, Dokter Diani.
Terima kasih
Terima
Prof.
kasih
Inki.
semuanya, Dokter.
Izin pamit
Pamit.
ya. Ya.
Assalamualaikum Kak.
Salam.
Terima kasih.
Terima kasih dok.
Terima kasih Dokter Dina. Terima kasih Dok. Terima
Terima kasih
kasih.
Nina, Dokter Sama. Sehat
Kasih Dr.
selalu.
Yani, Prof. Inki.
Thank you. Izin live.
Izin live.
Terima kasih, Liv.
Terima kasih.